bones, and doing it in a way that is really outside of within, but also outside of the medical paradigm. And I really respect what he's doing in the world. I always try to align with people who think this way. And he is also very familiar with Osteostrong, Dr. Jaquish, who helped us design our technology that we use at Osteostrong. And after speaking with him and seeing that we were included in his book, I thought, this is a guy that you guys would probably want to hear from directly. So Dr. Lucas, back to you.
All right, Kyle, for some reason, I couldn't hear you and all of that, but I'm assuming that everybody else could, since nobody else said that they couldn't hear you. So Kyle, if you could just shake your head and tell me that you're done. Okay, great. And you can still hear me, right? Yeah, okay. Well, I don't know why I don't have audio, but the good news is I don't need it. So as long as you can hear me, then we will just keep going. So, all right, thanks for that. I hope that was inspirational. A couple of housekeeping things as we get moving forward. Somebody had asked if we were recording this, and thank you for that reminder. Yes, we are recording this, and this will be available for replay for about 7 days. You'll get an email when we're done with a link to replay. So you'll have access to that. And then with the Zoom in webinar, you can always make the speaker bigger or smaller, so you can get as much or as little of myself and Kyle as you like. We do have a free offer at the end. We'll talk about some exciting announcements too. I didn't mention, if you have any technical issues like I'm having right now, if I were you, what I would do is exit and come back in. I won't do that, since that would not serve you. So anyway, we don't need for you guys to hear me, although we will. Hopefully, Kyle, you're not going to be able to actually advance the slides, so we're going to have to figure that one out, but we'll work on it. Nancy, to answer your question, this will be about an hour long, and we are going to, actually, I'll just talk about that right in a second. This is right here. It's about an hour long. That last slide that said disclaimer on it, I do just want to mention, of course, this is the physician thing where we can't make a physician-patient relationship. And I think that's probably pretty obvious at this point by listening to doctors online and through platforms such as this. But what I am planning on doing is talking about really what is osteoporosis, why we lose bone, things to watch out for, and then how we stimulate bone growth. And then ultimately building blocks for bone. We did flip those two, so the stimulating bone growth is in the middle of that. I do want to leave time for questions. I think it's really important in this platform. Obviously, if you guys can see, we have almost 450 people in the webinar. So make sure you put the Q&A or the questions in the Q&A box. We'll get to them at the end. We'll go through as many as we can. Try to not put them in the chat, because with this many people, there's no way that I'll see them. I also can't if people are raising their hands through the platform, I think that'll slow us down too much. So if you have questions, just put them in the Q&A and we will get to as many of them as we can. So I'm assuming Kyle probably said something about me and I don't know what it was. So I'll just introduce myself real quickly. And basically, I'm an orthopedic surgeon. So I trained in orthopedics as a traditional orthopedic surgeon with the goal of helping people surgically, and did a lot of good as an orthopedic surgeon. But about a decade into practice, realized that I was really more interested in helping people to avoid the things that I was providing rather than doing the surgery that I was trained to do. And so I made this very challenging decision to leave the traditional medical model, got some additional training, another board certification in anti-aging and regenerative medicine, a fellowship in functional medicine, and then created two kind of parallel companies. Optimal Human Health came first because that's what made sense at the time. Optimal Bone Health is the sister company that focuses exclusively on osteoporosis. And what's great about the Bone Health platform is that it uses the framework for Optimal Human Health, which I'll share here. It utilizes this framework, which we have found to be helpful for so many things. So many things that we deal with as patients and as really customers of the traditional medical model are not served by that model. Unfortunately, it is not good at handling diseases like osteoporosis, heart disease, diabetes, dementia, these things that are unfortunately also the biggest killers of adults in the United States and throughout the world. It is good at some things, and I don't want to despair the system. It is really good if you have a heart attack and need treatment, if you have trauma, if you have an infection. So we have to use this system for what it's good for, but what it's not good for are the things that take a more global approach, a comprehensive approach. And that's the framework that we built here. So we call this our optimization pyramid, and it's sort of grown over time. But basically, the idea is that we need to treat all of these chronic diseases from the foundation up. And this is just what we don't have time for in the traditional medical model. We don't have time as a doctor with a 7-minute visit to talk about nutrition, exercise, sleep. What kind of connection do you have with your community and your family? What kind of mindset do you go through the day with? What's your spiritual connection in life look like? There just isn't enough time in 7 minutes to have that conversation, nor are most doctors trained to do that, right? So only once those things are actually addressed can you then take that next step and talk about targeted supplementation, hormone optimization potentially, or replacement, and then peptides if that's something that people are interested in and open to and indicated for, and then pharmaceuticals, but pharmaceuticals only at the top, right? Like that should be after you've done everything else. After you have a comprehensive plan in place, do we talk about drugs? And you'll see as I show later that the system is really just upside down, right? We aim for drugs first because it's quick, it's easy, and kind of effective. You guys probably know this about osteoporosis, but I'm just going to dig into some of the statistics because it is really helpful, I think, to say that hip fractures, which I treated a lot of in my practice, hip fractures are scary. They're scary because they can kill you. Sure, 20 to 30% of both men and women will die within 12 months of a hip fracture. But that, for me, actually was not the worst part. The worst part is the loss of independence. The fact that 6 months after a fracture, the majority of people that regain independence still can't walk across a room unaided. So the fact that 1/3 of people will lose their independence and require full-time care was the worst part for me, because those are the patients that would survive and be miserable. That 30% that regain independence, like I said, is not likely the independence that they once had. So this is ultimately what we're trying to avoid at all costs. And yet, with those scary statistics and that stark reality, when we look at the leading causes of death, we can see that accidents is in there, but we don't really think of accidents for the most part as falls, right? Actually, accidental deaths, as we age, falls is the #1 cause of accidental death, which ends up being the #4 cause of death overall. But yet we talk about things like cancer, heart disease, and dementia and diabetes. We hear that nonstop, and yet very little discussion of osteoporosis, bone health. We might look at this graph and say, oh, well, age 85 and older, gosh, that's a ways out. And it might be for a lot of people that are on this call. But the reality is that if you want to not succumb to this big yellow bar at age 85 and out, you need to deal with it in your, honestly, really probably 20s and 30s, but let's at least say 40s, 50s, and 60s, right? You need to prevent this big yellow bar from happening earlier on. So I want to take just a quick moment and talk about the way that I view osteoporosis. Now, when I was treating patients surgically, I would view osteoporosis as, oh my gosh, this bone is terrible. How am I ever going to fix it, right? I can't put enough hardware in here to actually make this thing stable, because it's like putting screws in marshmallow. Not that anybody's ever tried that, but you can imagine what that would feel like. My views on what osteoporosis is that, yeah, we get a DEXA, and yes, we have a T-score, and we can do all those things. But what really it is an imbalance of metabolism. It is the deficiency of turnover and building up. It's the inability of the bone to maintain its architecture, its tissue quality. Ultimately, it's an increase in the risk of fracture. And again, that's what we're trying to prevent. And as I mentioned before, in that 7-minute visit, nobody can deal with osteoporosis unless you're just prescribing a drug. And that's why there's no specialists in bone health. There's no specialist in osteoporosis. Yes, you might see an endocrinologist that says that they deal with a lot of osteoporosis. Some orthopedic surgeons have fracture liaison services, and that's all fine. But really, they're just talking about drugs because that's all they have time to do. There are some exceptions to that, but for the most part, that's the reality. And part of that is because, yes, they don't have time. Yes, they don't get paid for it, but really, they're not trained in it. To find a physician to talk to you about nutrition and custom supplements and exercise and hormone optimization, man, good luck, because there are not many out there that can do it. So let's get into this concept. I'm going to go through this section and then we'll bring Kyle back on. And Kyle, I think we'll just have to use like hand signals. We'll go next slide, something like that. So I want to talk about why bones break down. And this is really, really important because, as I mentioned, if you want to prevent that fracture in your 70s and 80s, You really have to start in your 30s, 40s, and 50s. And I would argue, honestly, probably in adolescence, but maybe that's unrealistic in thinking. But we created this framework around how we view improving bone health. And I came up with the 4R method because I wanted to be able to have something that was easy to remember, that helped people to understand how to do this both with us, but also, and more importantly, on your own, because we're a small practice. I was actually just talking with my team today, the fact that we're booking into January, because this is such a needed thing, and we can't handle the demand, even as we're expanding. So really my goal here is to teach people how to do this on their own. My goal is to show you all the things that you can do, that you have the power to do. I want to empower you to be able to use this framework on your own. And the first R of this framework is to just simply recognize why you're losing bone. We are told by so many different people that it is expected that we should lose bone as we age. And statistically, that's true. But from an anti-aging perspective, from a health span perspective, we really shouldn't lose much bone as we age. If we can maintain optimal nutrition, optimal gut health, optimal hormones, why would we lose bone? That doesn't even make sense. So yes, it's probably going to happen to some extent, but we should not expect that we should lose enough bone to even see osteoporosis as we age. If we do, it's because we didn't have a good starting point. But ultimately, at this point, we're losing bone. Most people here probably have osteoporosis. So let's recognize, why are we losing bone? What is the underlying condition? Is it purely genetic? Probably not, right? Genetics plays a role. I'll talk about that. But we need to look at what we use are blood labs, and I can show you how to do that, but also potentially functional testing, history taking, why are you losing bone? And we'll talk about that whole list. That's what this section is all about. I'll talk about the rest of the R's later. So, okay, why are we losing bone? I mentioned genetics. If your parents had fractures and they both had osteoporosis, there's a good chance that you're going to have osteoporosis too. But if you know that, you can then prevent that fracture, hopefully. So knowing your genetics is really critical. And there's another component of genetics I'll talk about in a little bit. This whole list, I could probably spend the full hour talking here, but this whole list is full of the most common reasons why we see loss of bone. Hormone imbalances in there, chronic stress, inflammation, loss of muscle, nutrition issues, smoking, alcohol, toxins. Diet's a big one. Nutrition deficiencies doesn't really say it. And then the last one on here is lack of physical stimulation. And this is an important one that I actually added because I'm talking to people that are in such a great place from this perspective, right? These are people that are using Osteostrong, right? You guys understand osteogenic loading. Such a great population to be talking to because you understand that you need this physical stimulation. And what I want to show you is that this is really good to use, and all of the other potential things that you can add to this program could potentially make your results even better. So that's really what I'm here to do, is to help fill in the gaps wherever they might be. So when we talk about these risk factors, this is getting into like the doctor side. So I pulled these risk factors from an article that was published by the NIH. And the whole goal of this article was actually to teach doctors what to look for. Because when doctors talk about when to screen, they're actually saying it's 65 or 70 for women or men. And then unless they have a risk factor. But when you look at this list of risk factors, and I'm not going to read them all, but when you look at this list of risk factors, this is everybody. There isn't a single person I know that doesn't fit in this category. Anybody that's gone back and forth on weight loss, that's been around air pollution, stress, right? Anybody that isn't a woman or of Caucasian background, right? Like this is so many people, and yet we don't screen people early enough. But this is where I get this list from, to say of the things that we could potentially look at as a cause of bone loss, they're all right here. It's right in front of us. And I mentioned earlier, the challenge of stopping that fracture in your 70s and 80s is that you have to start really early, 30s and 40s. Not to say you can't do something in your 70s and 80s, you absolutely can. And I'm not saying you can't. But if you know people in their 30s and 40s that are at risk, I would strongly encourage you to let them know that they need to pay attention. And I put this on here too, because understanding what your peak bone mass is really important. Now, everybody here has probably already had a DEXA, so at least we have that going for us. But if you don't know what your starting point is, and I'll talk about this later, if you don't know what your starting point is, it's really important that you know, so that you know how well you are improving. And then ultimately, when we come up with a plan, that plan is to figure out what it is and then reverse that thing, right? Aim your energy at that thing. And again, if we go back to the very bottom of this list, we can see that deficient physical stimulus is on there. And again, you guys are already in that boat, right? You're already in a place where you are able to use the osteogenic loading equipment, and you're able to take care of this one. So you can check that box, and that's amazing. I work with so many people that don't have access to osteogenic loading equipment. So when I give this talk, I'll say it, we'll talk about it. But unfortunately, not everybody lives near a center. And I think I can blame Kyle for that, but we'll let that go. Expand faster. So anyway, everybody, like I said, probably knows what a DEXA scan is. I want to talk about DEXA a little bit, again, because it's important to know what your starting point is. And then I want to mention this thing called REMS, not because it's a good alternative. I like it as a better test. It's just not very available, but I want people to know that it exists. I mentioned this earlier, that screening starts way too late. If you know anybody that is at risk, let them know, because 65 and 70, the horse is way, way too far out of the barn, because we all have more than one risk factor. And I think that's pretty obvious. So DEXA, like I said, everybody's probably had one. Everybody knows it's the gold standard. In fact, it is the actual definition of osteoporosis. The challenge here is that it only measures density. And it doesn't really do a great job of that because it's a two-dimensional image. So it can't really separate between cortical and trabecular bone. And Kyle's going to talk about that when he talks through that section. There's also, what I like to point out, some high variability from machine to operator to software. So one machine is not going to give you the same results as the next machine. And even if you did use the same machine, a different tech could give you a different result than another tech on the same day. So there's some issues with this. Now, we still use it because everybody has access to it. For the most part, it's inexpensive, it's low risk. It gives us information, but there are alternatives. The REMS, if you can find one, and this is one of the reasons why I felt like I was meant to talk about this topic, is that there happens to be one in Asheville, North Carolina, where I live. I don't own it. Call it coincidence, call it whatever you like. But people travel here to get a REMS. There's another one in North Carolina. There's one in New Jersey, one in Texas. They're more frequently found in UK and in Europe. But it's an ultrasound. It has the ability to differentiate both bone density and give you a T-score, but also looks at, gives you a fracture risk assessment. So it can look at bone quality. Now, the question is, how good is it? I think it's pretty good. And if you look at the data, I think they look pretty good, and it can help differentiate people that have low bone density, but reasonable bone quality. Doesn't mean we don't treat it. It just means we can be less worried about it. And that's what I really like about it, is it can help to ease that anxiety around the diagnosis of osteoporosis, because that's real. The challenge is, like I said, there aren't very many of them, and insurance doesn't cover it. From a biomarker perspective, I have the list in here of all the things that we do. And this is sort of our basic panel. There's actually 2 slides of this. You don't have to rush and write this down. This is actually on our website. But the whole point here is that when we are looking for causes of bone loss, you need to look at more than just the bones. You need to look for causes of inflammation. How much inflammation do you have? What's your metabolic health like? What's your cardiovascular health like? Because let's face it, if we prevent you from falling and having a fracture, but you have a heart attack, that didn't do you any good. So we have to address all of those chronic causes of death and disability as best we can. We need to look at thyroid function. Are you high? Are you low? Are you on replacement? What kind of nutrients can we measure in blood that you could potentially be deficient in? What do your hormones look like? And then, yes, the bone biomarkers, right? Or bone turnover markers, C-telopeptide or CTX and P1NP. If anybody's listened to my YouTube channel, I talk about these things all the time, because those are the markers that we use to monitor improvement over time. Yes, people get DEXAs as well, but it takes 6 to 12 months or more to see improvement on DEXA, whereas you can see a change in P1 and P from month to month. I mean, so you can really help to guide treatment modalities. We like to put them together in this thing called a scorecard. This is not a validated research instrument by any means. This is just our attempt to help people to understand how they're improving over time. And what's great about this is that they do improve. You know, even if they're making subtle improvements, but they're improving things like vitamin D, and their CRP goes down, and their omega-3 to 6 ratio gets better. Like, these are all small wins. And that's how we get better, is that we stack small wins. All right. And then functional testing. I'm not going to spend a lot of time here because I could talk for an hour on each of these topics, but just to understand that you can only get so much out of blood. Working with somebody who can understand a stool study, in-depth nutrition evaluation, and cortisol testing, to understand what's happening in the adrenal glands. These things can be really helpful in helping people to understand what's going on with their body and where to direct that treatment. And then lastly, another look at genetics. From a genetics perspective, we don't know what the SNPs are around bone loss, which is interesting. But what we can say is that there are genetics that'll help us to determine how to best optimize your body. And this is just from the panel that we use. All right, so then let's get into the bone loading part. And I just want to mention, as we get into this, there are a lot of things here that I'm going to talk about that you could learn about. You might be able to get some information on, but you're going to have a hard time doing on your own. And this is the difference between getting information and applying the information. So I want you to kind of take all this in, write down the things that you need help with, and then figure out who can help you with them. Don't just let them slide off of the table. Okay. Some of these things you can absolutely do yourself, like this first one. So we're going to talk about how to stimulate bones to grow and osteogenic loading. And so, Kyle, if you want to unmute yourself, I'll let you do this part. I'm just going to go ahead and advance to this slide. And then if you could just use your hand and let me know, and I'm going to try to figure out why I can't hear everybody.
Okay, can you guys let me know if you could hear me, because Dr. Lucas can't hear me. You guys, can I get somebody say yes? All right, perfect. Thank you, Christine. All right, that's all I needed to know, and you could hear me too, Doug.
In fact, I can hear you now. Yeah, I'm good.
All right, perfect. Okay, great. So I've been getting questions on this since I started the company back in 2012, which is, how does this actually work and what are you doing? Well, you have to understand there was a guy by the name of Dr. Julius Wolff, and in 1890s, he was the guy that did the research that discovered that if you put enough force on bone, it will respond by getting stronger. In fact, it was such an impactful study. It is known to this day and taught in medical schools, called Wolff's Law. And so for over 100 years, doctors and chiropractors have known about Wolff's Law, but we really never knew how much pressure was actually needed to trigger osteogenesis, or rather to say the development of new bone. And so then there was a researcher by the name of Kevin Deere. In 2012, he decided to conduct a study to find out, what is this minimum dose of responsive pressure? Like, how much pressure do you actually have to receive to get your central nervous system to start building new bone? And so what he did is he attached these accelerometers to over 1,000 subjects, and he had them jumping off of different levels and doing different activities. And he expressed the amount of force that they were able to generate in terms of multiples of their own body weight, which makes sense, because somebody who's 250 pounds versus somebody who's 100 pounds, it would be more of a measurement of how many multiples of their body weight, given the size of their bones. Anyway, the study was interesting because at the end of the study, he concluded that the only people that were able to trigger osteogenesis were ones that were able to experience a minimum of 4.2 multiples of their own body weight. In fact, it was like discovering the boiling point of water, that anybody who got less than 4.2 multiples of their body weight didn't see anything. So it was this gradual effect where you set a little bit of pressure, did a little bit of good, and more pressure did better. It was nothing even started to happen until 4.2. Now, we only know this, the exact amount of pressure needed to trigger osteogenesis in the lower extremities or your legs, specifically your hip joint. That was the only thing that was tested in this particular study. But as you're sitting here thinking about it, a lot of people ask me, in fact, one of the questions that came up is, how's this different than just doing isometrics? Well, when you're doing isometrics, you're only doing one multiple of your body weight. You're just holding it. You're not ever getting to 4.2 multiples of body weight. And so Dr. Jaquish, Dr. Lucas, and many other people, professionals, understand that osteoporosis isn't really a disease. It's more of a deconditioning of bone, and anything that could be deconditioned can be reconditioned. That is the real premise of this masterclass and what we do at Osteostrong, why we exist. And so we got together with Dr. Jaquish. We created devices specifically that allowed you to generate many multiples of your body weight to trigger osteogenesis. Next slide. Okay, now many of you will recognize this. This is an old user interface we had on our program, but one of the things you'll see here is we have a woman who's sitting there on the machine, and she's in her mid-60s. She weighs about 115 pounds, and the top picture shows you on the bottom on the screen there that she's showing this in the red numbers that she's putting 113 pounds of pressure. Now, once the device gets into position and locks into place, as you know, she starts imposing force on the devices. And on the bottom screen there, you see that she's imposing over 1,000 pounds of force through her lower extremities, which is never before even considered doing that to somebody at any age, let alone in her mid-60s. Yet there she is. I'm having a conversation with her. She's not in pain. She's not getting fatigued, and she's not sore afterwards. Yet she's able to far exceed the minimum 4.2 in her lower extremities of her body weight so that she could trigger osteogenesis. Also notice too that her knees have dropped from the top picture to the bottom picture. And while the foot plate and the back seat have not moved, her knees have dropped, which shows you that she's actually able to compress bone and joint in this position. It's incredibly powerful stimulus. And you'll see that here in this next slide. Go ahead, next slide. The benefits you're going to get from this, many of you know. And when you think of fractures, people's mind automatically goes to bone density. But in reality, there's generally three things that contribute to a fracture. Bone density is the most obvious one, but it's also muscular strength and balance. You've heard that pride comes before the fall. Well, a fall comes before the fracture. And so to prevent a fall, having muscular strength and improved balance will help you even prevent from having impact that might create a fracture. So having all three of those are things that Osteostrong is going to deliver. So we see radical increases in bone density, physical strength, increased balance, but also improvements in posture, decrease or complete elimination of joint and back pain in many cases. And then, of course, reduced blood glucose. And you may be thinking, how is that even possible? I'll explain that in just a moment. Next. All right. Now, this is an interesting slide, and you might have seen this in your Osteostrong. So there was a meta-analysis study, and whenever you hear there's a meta study, it's a big deal because they're looking at many different studies and a particular field of study to try to get closest to reality. Now, Osteostrong wasn't part of that study. Our first published study wasn't big enough to be considered as part of a meta study, but we got those results and compared it. And this particular meta-analysis study looked at anything that was increasing bone density to find out how effective it was. Doing supplements actually slows down your bone density loss. In fact, everything there in the middle, people were taking some basic supplements for building bone density. And you notice from taking no supplements to just no activity and taking supplements, there actually was a reduction in the loss of bone density. Added walking or doing whole body vibration did nothing to develop bone density. So we often get questioned, I got a power plate or I'm doing vibe plate at home. Why do I have bone density loss? Or people saying, you know, I lift weights, I've exercised my whole life, yet I still have osteoporosis. Why? Well, when you start realizing that the amount of force needed to trigger osteogenesis is so high, typical exercise is very ineffective, even weightlifting. However, there was one study right in there in the middle where they did have a study that was doing weight-bearing exercise. It was, this particular study was a one-year study, and the people in the study were lifting essentially as much weight as they could possibly lift. It was a highly controlled study. There were personal trainers and they're helping people, keeping them from getting injured. And as you can imagine, there was a high subject dropout rate in that particular study. But the thing I do like about that study is it did prove Wolff's Law that if you're doing an incredible amount of loading on your bone, you are going to get a result. They saw about a 1% increase in a year. You have the pharmaceutical options there, bisphosphonate drugs, which are the largest class of drugs that you will see that doctors prescribe. And the challenge with those, they do work. There are side effects. I'm not going to bash pharma. That's not what I do. The challenge with bisphosphonates is you're really only supposed to, I'll leave that up to Dr. Lucas. The challenge with bisphosphonates is you can only take them for about 4 years, and then the side effects start becoming more and more dangerous. I did run into one member one time, and she'd been taking bisphosphonates for about 12 years because her doctor was just prescribing her a different one every 4 years. That was medical malpractice, in my opinion. Then you have a bone anabolics, which is a rare drug that is only prescribed in extreme cases. It's a teriparatide made by Eli Lilly called Forteo, and it will do a great job. It will build bone density. In fact, subjects saw almost a 7% increase in 1 year. The challenge with that drug is the biggest and the scariest side effects is potential bone cancer. So they only prescribe it when fracture is imminent. And then you have the results from the study that was done by Basil Hunt and Dr. Jaquish in 2015. And subjects in that study, there was about 20 people in that study, and they saw an average of a 14% increase. and bone density. Now, here's the most notable thing about all these different studies. In the meta studies, all those studies were 1-year studies. They were all done on postmenopausal women. The study that was done on osteogenic loading was a 6-month study done on postmenopausal women. So it was twice the results of the most powerful medication in half the time. Next slide. Now, this is I'm going to give you some recent studies here, because one of the challenges is, we have hundreds of physicians that refer Osteostrong now. And the main reason why they started doing it was because we were marketing directly to consumers. We tried to go to the medical community in the beginning, and while doctors understand fundamentally that this should work, they just aren't taught this in school. And because they're just like nutrition and other things they aren't taught, they just don't know what to do with it. But they started seeing results from their members. And so over the years, more and more physicians have been referring people to Osteostrong. This was a study done by Ann Sung. She was a contractor for NASA. And so NASA is always concerned about bone density loss of its astronauts who spend time in outer space. There's a couple interesting things about this study. It was a small pilot study. There was only one subject, and it was the researcher herself. Now, she is a competitive power lifter, and when she did this study, she was only 31 years old. She was looking at physical strength and the density of her cortical bone, which is measured by the DEXA scan, and she did a couple of different blood tests that show blood turnover markers that show that you're making bone. Go ahead, let's look at the results from on the next slide. Now, you wouldn't think a 31-year-old woman who'd been doing powerlifting would see increases in bone density, yet she saw an average of 6.28% increase in her cortical bone density throughout her body. And I believe that was a 9-month study, might have been 6, might have been 9, but right around there. That was amazing for such a young woman to see that much increase. Also, especially someone who'd been doing high power lifting. The other thing that she saw is a 54% increase in the amount of force that she could generate on the devices that you guys use at Osteostrong. And what was amazing was, and I was listening to her give this lecture, she said she saw a 12% increase in the amount of weight that she could actually lift in the gym just after 4 sessions. And she paused when she said that. She says, I am a professional power lifter. She says, for me to see a 2 to 3% increase in the amount of weight that I could lift in the gym takes me about 3 months of full-on effort at the gym. She said, I essentially achieved in 1 month what would have taken me 12 months in the gym, 1 month at Osteostrong versus 12 months in the gym. Now, the other 2 things over there on the side, BAP and NTX1 test, those 2 tests are essentially showing you how many osteoclasts, increase in osteoclast production, which is the cells used to build bone, and osteoclasts are the ones that absorb your bone. She saw a 39% increase in her osteoblastic bone building activity and a 41% decrease in her osteoclast or bone reabsorption or bone breakdown.
I just want to pop in here for a second too. So what's really funny about this study is I actually know Ann Sung personally. And so I just wanted to share that it's one thing to say like, oh, this, middle-aged power lifter. No, this lady is an intense power lifter. She sends me videos of her working out, and she is no joke. So the fact that there's this much increase in using a different approach in machine versus somebody who was really crushing it in the gym is pretty remarkable.
It's pretty much. And I will say this, just on a side note, with what we see with athletic and performance improvements across the board, whether or not somebody's a swimmer, a golfer, a bike rider, a long distance endurance athlete like an Ironman or triathlon or something like that, I have never seen an athlete not have dramatic improvements, so much so that I say I predict that in the future you'll have 2 types of athletes. You'll have ones that use Osteostrong and ones that simply lose. Now, I point out this and I make that little side note there, not because I'm trying to impress you, but impress upon you those 3 pillars of a fracture, which are bone density, strength, and balance. Osteostrong shows you right here on this one study that it's doing both in a dramatic way, the strength and bone density. Next slide, please. So one of the things is, because the Hunt and Jakewish study that I showed you on the first screen was a small study. Research costs money. It's a lot of doctors just like, well, that's not a big enough study, and that's a fair statement. No, I'm not. It is a small study. Now we're seeing these types of results and varying levels of them in our Osteostrong, but seeing them and then actually having a study that somebody in the medical profession can feel confident is another thing. So we went ahead and spent the money right before COVID to do 2 very large studies, for us anyway, and they just completed last month. One of the abstracts, or a piece of the study, a piece of the first study, actually dropped in January and was presented at the Endo 2023 event in Chicago this past June to 7,000 endocrinologists. This study was done on postmenopausal women. Subjects, there were 140 subjects. It was a 9-month study. 70 were in the Osteostrong group and 70 were in the control group. And half the people in each of the two groups, both control and Osteostrong group, were on bisphosphonates. The other half weren't doing anything. They are testing cortical bone density, trabecular bone density. And if you guys don't know what that means, cortical bone is the bone on the outside of your bone. Trabecular bone is the inside of your bone. They were looking at balance, strength, and HbA1c, which is the long-term blood glucose marker that you look at to see how your blood glucose is doing over a 3-month period of time. Next slide. Now, the part of the study that we actually did get to see, I haven't seen all those results yet, was and this is what was presented in Chicago, was the effects on the lumbar region in 9 months. A 2.21% increase in the cortical bone density and a 1.73 increase in trabecular bone density in the Osteostrong group. The control group saw a 0.1% decrease in cortical and a negative 1.3% decrease in trabecular bone. And that stands to reason that you would see that, considering that half the people in the control group were taking bisphosphonates. So they were able to at least slow, it wasn't as dramatic as a decrease, because a bisphosphonate will only increase the cortical density, but will not affect the trabecular density of bone. There was and put it another way, there was 179% greater improvement in cortical bone density over the control group, and a 200% greater improvement in trabecular bone density over the control group. So Osteostrong did great. The average T-score in the lumbar spine went from average of negative 2.7 in the Osteostrong group down to negative 1.93. So that's a dramatic improvement. Next slide, please. Now, I'm just going to touch on this for a second. You guys know this. If you go to Osteostrong, this was we looked at the data. This wasn't a published research paper. It was more of a internal case report that we did, where we looked at the data from 500 people using Osteostrong for 4 years with an average age of 52. Saw an increase of 290% on average, how much force that they were able to generate on the devices, in which, if you've been using Osteostrong for any period of time, you know that this starts translating to quality of life outside of Osteostrong. Next slide. Now, this was part of the Jakewish and Hunt study. It was a different study. It was still about 20 people, a little small. So we're super excited about the Greek study and the other one coming out of Sweden. What this one was looking at was A1C. So we saw that people were getting really strong when they were going to Osteostrong, but you're not getting bigger muscles, you're just getting stronger muscles. And so the idea was, well, if this is happening, then how do you prove strength beyond how much force they're creating? And then so we decided, let's do an A1C study, because your insulin receptors are in your muscle cells. And if we're increasing the density of the muscle tissue, then in reality, we should probably be increasing the number of insulin receptors in the muscle cells. And so this was a 3-month study done on people who are right on the edge of having type 2 diabetes. They didn't have it yet. They were unmedicated. And they were just told, don't change your eating habits, don't change your lifestyle, just start doing Osteostrong. And in 3 months, they had a greater decrease in A1C than in studies where they were using cardiovascular only, metformin only, weight-bearing exercise, or restricted calorie diet. So Osteostrong shows it actually has, in and of itself and by itself, a greater effect on blood glucose levels, than any of those other modalities. Now, I will say this about every other option there between cardiovascular, metformin, weight bearing, and restricted calorie diet. With those things, you could stack them and do them all at the same time. You're going to get a compounding result. So this is very positive, very exciting. And we've seen many of our members actually coming out of type 2 diabetes. Next question. Oh, and if you're interested in weight loss, it will help you keep off weight. Next slide. I don't think I'm going to get into the details. This was just the one of the studies that Dr. Jaquish had done, if you want to reference that study.
I actually put this in here just because I wanted to show my poor highlighting capacity, but actually really it's just this multiples of body weight. I don't know if you guys can see my cursor, but the fact that you can generate 9 multiples of body weight is just astounding to me. You know, thinking, because I love to lift weights, even if John Jaquish says that I shouldn't. I like to lift weights because I like to lift weights. But the idea that I can put 9 multiples of body weight through a joint it just blows me away. So that's why I wanted to have that in there. Yeah. And then this was sort of my summary slide. So I'll pick it up from here. Thanks, Kyle, for that. I really appreciate it. So I'll pick it up from here and just say, you know, when people ask me, because we do a lot of consultations for bone health, and people say, what is the perfect exercise? And the answer is, I mean, honestly, if you want the biggest bang for your buck, there is no question in my mind that it's to do Osteostrong, because you can maximize your ability to load bone, you can maximize your ability to improve muscle and the other benefits that was just discussed. People say, well, what about lifting weights? Well, for people that don't have access to Osteostrong, this is what we do, right? Because it is, as Kyle showed on the chart, you know, it does improve bone. You can do this in a way, I think, to make it even better than the studies show, but you're not going to get 9 multiples of body weight. You're just not. And so, yeah, it's a thing. And there are other reasons to do resistance training and other types of exercise. So I always look at bone health from the lens of health span, through the lens of longevity. Because again, if we only focus on bones and you succumb to something else, then again, I failed you. So I'd like to tell people, look, yeah, resistance training has other benefits. Let's look at your comprehensive program. I love reminding people that grip strength is one of the most important indicators in longevity from a physical perspective. Doing stuff like a farmer's carry, which is literally just carrying heavy weight over distance, right? Because farmers carry heavy weight. Walking outside, getting sun, getting UV light, getting exposures, forest bathing, if you will. Walking hills is a great way to build stamina, to improve your lungs and your heart. People ask me a lot about Pilates and yoga, and I think Pilates and yoga both play a role in maybe overall health span, you know, flexibility, core strength in Pilates I actually like over yoga. But the truth is, in both of these modalities, you have to be very careful. Both my wife and I recently, we were getting into doing hot yoga, and she ended up with a back injury and I ended up with a shoulder injury. So even us young people have to be careful with yoga, because it can be relatively dangerous. And especially with osteoporosis, you can put yourself in a susceptible position pretty easily. Balance training, I think, is important, especially as we get older, because while Kyle's right, a lot of people do fracture before they fall. And I see this as an orthopedic surgeon all the time. I'm like, what happened? I don't know. I just turned around to pick up my keys and I felt something pop, and then I was on the ground. So the hip actually breaks before you hit the ground, but people also fall. And so balance training, I think, is important. And then what I call tactical skills, which is actually like, how do you get up? You know, like, let's practice these things. Let's have the ability, the strength to be able to stand up on one leg, or, you know, with 2 legs and 1 arm. So practicing those things, I think there's definitely benefit, but it really depends on what your starting point is. All right, so then to finish this up, we're going to talk about the building blocks. So let's go back and think about what we just did. What we just did is to talk about, in our framework, recognize why you're losing bone, reverse those causes of bone loss. Part of that is everything that we just talked about. You need to stimulate bone, but we also need to provide your bone what it needs. So that's what we're going to get into here. So we go back to that same list. Why are you losing bone? And now we say, okay, let's reverse this problem. Well, which one of these things is it? Right? So, you know, some of these things you can't do anything about. Genetics, you can't do anything about, but a lot of these things you can. Yes, you can find an Osteostrong location probably close to you. You can work on gut dysfunction. You can work on nutrient deficiencies. I'll talk about in a second. Go down the list. There really aren't very many things in this list that you can't do something about. And I look at our approach as really splitting the gap between the traditional system and what I like to look at is what I call medicine 3.0. And for those who don't know where that comes from, Peter Attia is he doesn't know me, but he's a mentor of mine. I love the way that he has a podcast and a book, and he talks about medicine 3.0 as the next level of care, which will be customized, which will use good biomarkers and will be sort of agnostic to the insurance paying system. I'm not as optimistic that we'll get there as he is, but I like to look at it from that perspective because our goal is to prevent fracture. Now, the traditional system goal is to prevent fracture too, but like I said, the way that they do it is upside down. They go right at drugs because drugs are quick to prescribe. You can do it in 7 minutes and you can help prevent a fracture, at least in the short term. It's true. But it really needs to be a long-term perspective. And drugs, as Kyle mentioned, they're all short-term. And I'll talk about that in a second. But really, we need to talk about that same framework, right? That same lifestyle, accountability, supplementation, hormones, peptides, and then, and only then, do we talk about drugs. Now, I do prescribe drugs, so I'm not totally anti-drug. But I can count on one hand how many times I've prescribed drugs after hundreds of consults for bone health. So I just think that by the time we go through this process, you just don't need them. Or you don't need them now. Maybe if we fail, you'll need them. I haven't done that yet either. So, all right, so we go back to this optimization pyramid. So what do we do? Well, we need to talk about these pillars of health. Now, I'm just going to ignore the exercise part because I think we have talked about that adequately. But let's talk about some of the other important ones. Sleep. I could talk about this for an hour. I'll just say these two things. One is, maybe four things. So one is you need to get adequate sleep. Hands down, the most important modifiable thing you can do in your life. Naps are okay as long as they don't interfere with your nighttime sleep. And I have this conversation all the time. Sleep drugs, almost for the most part, terrible. I almost never prescribe them because they will impact your sleep quality. Even if you are sleeping, you're actually just usually unconscious, depending on the drug. Melatonin actually will stimulate osteoblasts. So if you tolerate and do well with melatonin, it's a twofer because you can actually stimulate your osteoblast or the cells that build bone, as well as get better sleep. I don't like it. And I would say about half of my patients don't actually do well on melatonin. So then I saw a lot of questions and I was answering questions as we went, which was great. Actually, it was a really good opportunity to get through some of the questions. And a lot of them were about nutrition. So let's talk about my perspective of an optimal bone health diet. And this will be certainly the most controversial thing I say all day, but there is so much confusion in the bone health space. And I feel like we have unfortunately been hijacked by this really unnecessary back and forth between the plant-based community and an animal-based community. And that this conversation around pH really gets in the way of what is ultimately a good bone health diet. So I'm just going to put out here what I recommend to my patients, and then I'll talk a little bit about alkaline and then vegan and vegetarian diets. So my perspective is we need the building blocks. You need the protein. Your bones are more than 50% protein by volume, right? It's not all calcium. We need the protein. So you got to eat the protein. We aim for about 1 gram per pound. I'm going to say that again, 1 gram per pound of body weight for most people. Now, again, I'm not making recommendations for anybody here. If you have chronic kidney disease, talk to your doctors. But in lieu of that, everybody should have the capacity to handle 1 gram per pound. Safety data goes up to 3 grams per pound, right? So as an almost 200-pound man, I could actually eat probably 600 grams of protein and not have any negative impact on my body, metabolically or my kidneys. I prefer protein from animal sources. It's better absorbed. Your body knows what to do with it. The amino acid profile fits, and it comes with a whole bunch of nutrients that you can't get otherwise. Then people say, well, what about my urine pH? I'll get to that in a minute. I already mentioned kidney function. I like to describe our approach to eating as a Mediterranean diet, maybe modified. It's an anti-inflammatory in general. I have a lot of videos on dairy on our YouTube channel, so I won't dig into it now. But basically, if you tolerate it, it's likely beneficial. The statistic that says that if you have 1 glass of milk, your risk of fracture goes up is garbage, totally misinterpreted by really well-known individuals I won't mention here. Carbohydrates, you really don't need them. However, most people will eat them, and that's fine. I would start with non-starchy veggies, then go to starchy veggies, then fruit, and avoid grains, gluten, corn, beans, added sugar, processed foods. I should add in there alcohol. All of those things are going to be net negatives. And this is where most people's heads explode. Well, what about my beans? Where am I going to get my protein? So then that goes to the alkaline diet. I just did another video on this. And honestly, I just, in doing the raw data for this video, I literally just talked straight for 45 minutes. So I have sympathy for my editors on this topic. But here's the thing. The alkaline diet principle has never been proven. There is evidence in petri dishes that osteoclasts will increase activity with acidity. Absolutely true, but we don't live in petri dishes. If you feed an animal the wrong diet, they will bleed calcium from their bones because they have no other choice, but that's not us either. We're not mice. If you want to alkalize your body, people say to avoid meat. There is no evidence that says that eating meat causes an acid response in your body. I'll talk about the human literature in a second. If you absolutely have to eat an alkaline diet, fine. Avoid sugar, processed foods, alcohol. We don't hear people say, don't eat chocolate and wine to alkalize your body, right? They say, don't eat meat. But yet meat is not the problem. It's the other stuff that's the problem. And I think if you want to avoid all those things I just mentioned, that's fine. You're going to be better off for it, but it's not because of the change in pH. Your body has such an intense capacity to buffer pH. We have such a narrow window of maintaining our body acid in our blood that whatever you eat is going to have no impact on your blood. I know this because I lived in the ICU and in the operating room and in those environments with true arterial lines where we're actually measuring pH. When somebody eats something, whether it be a hamburger or garbage hospital food, their pH does not change, because you can change your pH through what you're breathing, through how your kidneys work, through how your muscles work. You will not change your pH with food, period. I'll move on. That's a soapbox. I'm gonna get off of it. In the human data, we see that this is true because in a vegan and vegetarian diet, and I just put one publication on here, there are so many. If you eliminate meat, your risk of fracture goes up, and it goes up more the less meat you eat or the less animal protein you eat. And so I don't care what happens in the petri dish. I don't care what happens when you feed an animal a crappy diet. In humans, this is extremely predictable. And this even goes beyond what is called the healthy user bias, which means that vegan and vegetarians are by nature generally making better health choices rather than people that eat meat. Because people that eat meat are also going to be in the standard population of people that are, making bad choices like drinking more alcohol and smoking and staying up late and going to the bar. Health choices that are negatives. Vegan and vegetarian people generally don't do that. But yet, even with that, not being able to control for that, vegan and vegetarians still are going to have a higher fracture risk. So I think it's possible. It's possible to eat a quality plant-based diet for some people. I think it's going to be a small minority. And I don't think I've ever seen it, but I think it's probably possible. Anyway, if you are going to do it, because some people will do it for ethical reasons or whatever, and I'm happy to talk about all those, but if you're going to do it, make sure that you are supplementing B12, vitamin D, choline, creatine, omega-3, zinc, iron, iodine, all the things that you can't get elsewhere, okay? And the last thing on lifestyle is don't be afraid to be extraordinary. Talk about this in our podcast. Aim for optimal, not average. Not to say that the average person is bad. We need to elevate average because average is sick. So aim for optimal, not average. Success loves speed, determination, commitment, and consistency. So do all of those things for your health. All right, let's chat about supplements. So again, I could talk about each of these things for an hour. So to make this quick, I would just say that use a targeted approach. Use biomarkers when you can. Do not just throw supplements at a problem and think that you're going to improve, because likely you're missing the mark. Calcium is very controversial. Yes, it is recommended for everybody. We tell people to get it through diet whenever possible. We have plenty of patients that aren't even on a calcium supplement because they can get adequate calcium through diet. I don't think we probably need 1,200 milligrams. I think that's way too much. Most countries, actually every other country except for the US, is more like 500 to 700 milligrams, which is very easy to get through diet. If you take calcium alone, it will increase your risk of heart attack and stroke. So make sure you take it with vitamin D, vitamin K, preferably as MK7. And then we prefer the form MCHC or OHC, which is microcrystalline hydroxyapatite complex, or ostein hydroxyapatite complex. Easy for me to say. All these other things you need in the right forms. And again, I could talk about this at really long length. Some things to consider: dietary enzymes. This is why we get gut tests. We want to know how people are doing. Some foundational things like B vitamins, omega-3s are really important for anti-inflammatory and heart health risk. And then you got to get your basic minerals. All right, so now we've gone through the recognized part. We've gone through the reverse part up to the area of things that you can't do on your own. And this is where people start to get frustrated, because then they say, well, I want to do things like hormone replacement, or I've heard about these things called peptides, or what about the other things? And again, I could talk about all these things at length. And let me just say this about hormones. We are in a very unfortunate situation in this country and across the world, but more so in this country because we did the thing, where the research that came out in the early 2000s decimated estrogen and hormone replacement for women and men a little bit, but mostly for women. Just absolutely decimated the field because of the fear of increased risk of invasive breast cancer and stroke. I could talk about those studies all day long, and I do so, and you're welcome to listen to me go on and on my YouTube channel. But the summary is this: all of the studies that showed the bad things also showed that there was tremendous benefit from estrogen and potentially progesterone for bone. It reduced fracture risk, it increases BMD. If you can use it, if the risk benefit makes sense for you, I'd strongly encourage people to use it. How to get it? That's the challenge, because the traditional medical system will use generally an oral estrogen rather than a cream. Oral estrogen will increase your risk of blood clot. They'll use a synthetic progesterone called a progestin rather than progesterone, which will increase your risk of breast cancer and blood clot. And nobody will prescribe testosterone in the traditional medical system, except for rare exceptions. So how do you get it done right? That's a massive challenge. What you're looking for, in my opinion, obviously, is a topical cream to reduce the risk of blood clot. Basically makes it zero. Progesterone as a capsule, micronized progesterone, which is an incredible aspect for sleep, but it will also help with bone health. And then testosterone, which I view as pretty much the fountain of youth for both men and women. And it'll help with muscle mass, with skin, with clarity, vigor, vitality, libido, sexual function, across the board, all wins. The risks are very low, but they are real. So this is not necessarily for everybody, but definitely worth considering. We're big fans, if you couldn't tell. Peptides, I won't spend a lot of time here. These are things that are really, and I should just be obviously open that these are not FDA approved for anything. Hormones, estrogen and progesterone are FDA approved, but only estrogen for osteoporosis, and even then not generally used for it, just to satisfy the FTC. Peptides are not FDA approved by anybody for anything because they are not made by drug companies, but they can have an impact on muscle health and on bone health. Just make sure you're getting them from a provider that knows what they're doing. Avoid direct-to-consumer stuff. Oxytocin nasal spray, another fun one that will increase osteoblast function. Not well studied, but is used often in the sexual health space. And if you can treat somebody's sexual dysfunction and improve their bones, all the better. And then I'm not going to spend a lot of time here. I think Kyle covered it well, which is from a drug perspective, the bisphosphonates, I really don't like them. There is a time and a place for all of these things. But a bisphosphonate is only good for slowing down bone loss for a short period of time. It will not help build bone. In fact, it will decimate bone growth. The fact that DEXA changes is actually kind of interesting because it squashes osteoblast function. I see it in my tests all the time. So bisphosphonates, really only like them if you're rapidly losing bone and have no other way to control it. Prolia, I put in the same group. People were asking me this. So Prolia is also essentially an anti-resorptive. It has a slightly different function, slightly different risk profile. But again, it's essentially an anti-resorptive. It'll squash bone growth. Now it has safety data out to 10 years, but the risks start getting worse and worse. And then what do you do after 10 years? So especially for our younger patients, 40s, 50s, 60s, I mean, even 70s, what are you going to do after 10 years? Avidity, which is the new kid on the block, only goes out to 12 months, and it eventually squashes bone metabolism too. And that's the big issue here, is that it metabolically deranges your bone. So what's the long-term plan? Now, the anabolic drugs, Kyle mentioned Forteo and Temlos, and I actually do use these drugs in some circumstances for somebody who has severe bone loss, for somebody who is in a really, really deep, dark hole, and we're scared, right? We absolutely need to do something right now. I don't care about the risks. I got to do something, or this person's going to fracture. That's when we use anabolic drugs. And I use them because it doesn't squash bone metabolism. It elevates bone metabolism. But again, short time horizon. You know, what are you going to do after these drugs are used? And again, that's the traditional solution. We alter the bone metabolism. It's very short-sighted. The pyramid's flipped upside down. And again, there is a time and a place, and I could talk about those, but it's only after a comprehensive plan is in place. I hear this all the time. I have breast cancer. I'm on this drug. It's causing bone loss. Should I take a bisphosphonate? Maybe, right? But it's for a specific period of time. And let's also put all the other things in place, right? And those are the conversations that we have that can be really tough. So you might be asking yourself, how do I get all these things done? And whether or not you use our team or a team, it doesn't matter to me. I'm not here for that. What I'm here to say is find a team, and preferably an A team, because helping you to decipher these tests, helping you to get the biomarkers, helping you to put a plan in place is really important. You have to reach out and ask for help. So what does it take? Remember this, it takes time, 6 to 12 months minimum before you change course. You have to be consistent with what you're doing. You have to do all the behavioral changes. You have to really go trial and error, trial, retest, error, retry. You got to keep going. Having accountability either through a dietitian or through coaching, through all of those things. A physician-led practice, I'm a little biased probably, but is great because it bridges that gap, right? Not only can they use nutraceuticals and high quality ones, but they can also prescribe all those things, and they can provide you with a comprehensive program. Self-directed programs can be great. There's a few, at least I can think of, a few out there, and they're good at education. They're good at providing information, but then you have to know what to do next. You have to know what to do with it, and I see that frustration often. And also remember to do this through the lens of health span. If you fix your bones but forget everything else, then you probably didn't do yourself any good. And that's it. So remember that this is a comprehensive thing. Our resources are out there. The optimalbonehealth.com website is available. It has resources on it. We're changing things around a little bit, so that's going to change over the next couple of weeks. We're really pushing people to the YouTube channel because it is free. It is a lot of content. I think we have 170 videos on there. And you can follow us on social, Instagram and Facebook. It's a little bit more health optimization oriented. And there's a new podcast coming out like that. It'll be called the Dr. Doug Show. That's a little bit more health optimization oriented. And then the free thing I offered. So I want to announce this collaboration. So when Kyle and I first met, we were introduced by John Jaquish, and we were talking about the book and how we could best serve this community. And what we came up with was this idea that, man, we got to write a new book. We got to write a new book with the new research that's coming out and really make a more comprehensive book than the one that I'm going to tell you about, because there's so much good information about bone health out there. So we're going to try to get some exciting authors together and come up with, I think is going to be a really great opportunity to really educate some people. And then I have down here this free ebook offer. So this book right here, this is the book that I just wrote. Obviously it has my picture on the front, but the whole idea of this book is it is short. It is a jumping off point. It is for people that are looking for that step in the right direction for a comprehensive approach. It talks a little bit more about diet, drugs, supplements, what's wrong with the way that we treat patients in general. So it's available if you just go to this optimalbonehealth.com/ebook. You can download the PDF for free, and there's a link for Amazon. I think it's like $9 or something. So we're trying to get this into the hands of as many people as we can. If you want to talk about working with us, again, I'm not here to sell that, but just go to our website. You can schedule with our team. We have an amazing team of really well-educated people. This is an intimidating panel of young women that know a lot about gut health and know a lot about bone health. And I think that, there is certainly a role for that. So let us know what you need there. And then we're at the end. So like I said, I answered a lot of questions while Kyle was talking. And I know we're
to answer a few too. And
great.
As I was just jumping in, they were coming in so many. I do appreciate everybody's questions. And as Dr. Lucas is looking through some of those to see where he might either answer them here just to the group verbally or type an answer, I just want to say thank you guys for all jumping in here. We really appreciate it. We really did want to try to give you some value, and I know there's a lot of good information, bad information. Dr. Lucas did an amazing job on just knocking down some trees of bad information out there. So thank you for that, Dr. Lucas. But like I said early on, we do want to put on some more master classes for you guys going forward. So if you have ideas or suggestions for master classes, please share with your team, with your Osteostrong, and I will find the expert. We have a lot of experts in our hip pocket on a range of subjects. It doesn't just have to be about osteoporosis. It could be about other things as well. We're here to help. And with the resources that we have today versus 7-8 years ago, we could actually deliver some really high quality for you all. And so we're happy to do it. Any questions you want to try to answer here, Dr. Lucas, before we go?
Oh man, there's so many. I think there's a lot on supplements and a lot on nutrition. So let me just hit a couple of supplement things. When it comes to supplements, again, I would just encourage people to be very biomarker based whenever possible. You know, some of these labs, actually almost all of these labs, you can get on your own, especially in the US. I'm assuming we're mostly US audience here. So in the US, we have some information on our website about how to do this, but there is the company Life Extension offers direct to consumer labs. So you can get a lot of these biomarkers, be biomarker specific. And then I think one of the best sources probably is our YouTube channel, where I do dig into some of these supplements, and we'll be doing more. You can also leave questions and comments on the YouTube the channel, and we go through those every day. So if you want to ask specific supplement questions there, that's a better way to get a question. And then from a nutrient perspective, so we had several vegetarian people make some comments, and I totally expect that. And I'm not trying to be extremely biased in trying to put somebody off on the way that they eat. There is probably nothing more controversial than talking about nutrition, and I'm talking like religion, politics, even in today's world. So, but to answer these questions from the vegetarian team, it's mostly about protein, right? And so people are saying, why exclude beans? It's my primary protein source. So here's two big issues with that. If you've read any of the work by Dr. Gundry, he really digs into this, but it's this concept of lectins and anti-nutrients. So beans are not really designed by plants to be eaten, right? They're not the fruit of the plant. Plants don't want you to eat their beans. They don't want you to eat their babies. So they are going to protect those things with these anti-nutrients and toxins called lectins, potentially oxalates, phytates, depending on what you're eating. Those things can have an impact on your ability to absorb nutrients, inflammation of the gut, and some interesting other things. And so I just find them to be in general inflammatory, and probably in small quantities, maybe not a big deal. But if it's your primary protein source, that's a lot of beans. And I think that we're just not, as humans, our species is not designed, and it doesn't do well with that quantity of anti-nutrients. So even if you are getting that much protein through beans, and even if you're doing an amazing job of putting that amino acid profile together, you're consuming a lot of anti-nutrients and a lot of carbohydrate, which a lot of people can't tolerate. And so I see a lot of people that go down this plant-based pathway, and they end up gaining weight with metabolic dysfunction. Now they're pre-diabetic and obese, but they're plant-based, and ultimately their health is a lot worse off. So I think if you can wrap your mind around the idea that eating animals is not a negative. It is not a net negative, and now I'm getting into my personal opinions, but it is not a net negative for the environment. It is not a net negative, in my opinion, from an ethical perspective. And I'm happy to have this discussion all day long. We are, as humans, we have excelled in history because we were able to eat meat. Turning our back on that now is likely going to be to your physical detriment. All right, and I think we can just leave it there on that controversial.
Yeah, we could, you and I could probably answer questions for 4 hours because there's some good ones in there I want to get to. Listen, the basics, and you don't really want to get too in the weeds on this kind of stuff. It's really about controlling your environment through proper nutrition, through understanding your hormones. If you could do something about that, that's awesome. And then giving yourself the proper stimulation to build bones. That's Osteostrong. If you're doing some version of all three of those, you're likely going to have results. I do like to encourage people to get a test for hypothyroidism. That is one of the things that will inhibit your results at Osteostrong. And a lot of people aren't even aware that they have an underperforming thyroid gland. And so it's a simple, easy test to get done. And so when I encourage, and this is a big deal. I would encourage younger people to do Osteostrong. My teenagers go to use Osteostrong. They've had incredible results. My nephew had osteoporosis. They discovered he had osteoporosis about 19 years old, and there was nothing wrong with him. He had several broken bones, was able to reverse his osteoporosis because of Osteostrong. And so the earlier you get started, the better you're going to be. It's always easier to build on something that's already strong than to build up from nothing. But, you know, we have people who are now in their 70s, 80s, and 90s who've been going to Osteostrong for years, who now have the bone density of a 30-year-old. High five. That's amazing. Nobody ever sees that. Our doctors just have never seen that before. So we are super excited to be able to provide those type of results and to help you guys out in every way we can. So thank you for everybody for hopping onto our masterclass. I'm super excited about planning the next one. And so Guys, enjoy the rest of your evening, and we appreciate you for coming on. Thank you, Dr. Lucas.
Yeah. Thank you again for the opportunity, and thank everybody for your patience. I know we went a little bit over, but just means that we'll definitely have to do it again. So I appreciate everybody, and I appreciate you guys being advocates for yourself. I think it's really one of the most important things. All right.
Agreed.
Take care.
Thank you. Bye.